All right, I'm going to get started. So good morning, everyone. Beljeet Hundal with CWDA and CFPIC. We are here together to do a meet and greet with our partners from Anthem related to the child welfare side of county departments, and to help us understand better the services and supports that Anthem will provide to children, youth, and families involved in child welfare, as well as talk to us about the process with the MOU, hopefully introduce us to their child welfare services liaison as identified in the MOU. And we're going to try and do 30 minutes at the end, so around 11 o'clock, question and answer period as well. So please, you can definitely utilize the chat for that, or ask your questions during that time. I would like to ask Andrea from CFPIC to introduce herself, and then we'll get started from there.
Great. Good morning, everybody. I see a lot of familiar faces, but I'm Andrea Sobrato with CFPIC, and we're thrilled to be able to host this meet and greet for you all, and hope that you find it very valuable in light of the MOU process and all of the current issues like continuity of care and all the sort of on the ground issues that folks are kind of wrestling down. So we want today to be as valuable as possible. So do take Beljeet up on our offer. If you've got questions during the presentation, go ahead and start entering those into chat, and the Anthem folks will keep an eye on chat, but also we do want to save that 30 minutes at the end to work through some of those hot topics. We are recording this. The PowerPoint will also be dropped into chat in just a moment. So we're recording it. The PowerPoint, we will also host a recording of this on our CFPIC website in case you have other colleagues from your counties that weren't able to participate today. So with that said, I will turn it on over to.
Let me try and share my screen because I'm having problems with this coming up. So I'm more familiar with Teams than Zoom. All right. So can everybody see my screen? Is it full screen? Is that okay?
Yes.
Okay. All right. So, okay, great. Let me just go back over here. Hold on a second. All right. Let me hide this part. So, thank you very much for having us. We are very excited to be here this morning and sharing this information. It's great to see familiar faces or familiar names across the attendees also, like some of my old friends. And I know with Anthem, we've got our county account management program managers on the call this morning too. So I'm sure that you're seeing their names and they're seeing yours. So this is really exciting. I'm Janet Payne. I'm the director of our county account management team at Anthem Medi-Cal. And we are pleased to just be able to provide you with an overview, high level of Anthem Medi-Cal. I think most of you are probably familiar with the Medi-Cal Managed Care Program, so we're not going to get into detail on that. But I'll provide a few just high level overviews on who we are at Anthem, and then I'll turn it over to Eric with our special programs team to speak more about CalAIM and then what our involvement is with regards to enhanced care management for children and youth and the foster care population. And then towards the end, we'll turn it over to Jared Martin to just touch on the MOU process. So with that, I put on here that we're Anthem, but we're also known in California as Blue Cross of California Partnership Plan. And I like to say that because people hear Blue Cross, then they hear Anthem, then they'll ask the question, well, what about Blue Cross Blue Shield? So we always like to clarify that because Blue Shield is actually a competitor of Anthem Blue Cross in California. So you'll hear Blue Cross Blue Shield, but that's more towards our Medicare population or our large accounts, our federal employees, federal government population also, and it is a product line in other states. So I do like to share that information. Our legal name with the Department of Healthcare Services is Blue Cross of California Partnership Plan. That's our legal name on all of our documents, on all of our MOUs. But then we also go by Anthem. So just wanting to clarify that with you all. So with that, currently in California, Anthem Blue Cross covers 1.3 million Medi-Cal lives. And we are currently, as of 2024, we are the Medi-Cal Managed Care Plan in 16 counties. And this was changed from previous years when we went through the rebid process last year. And then as of January 1, the new service areas were announced. So here's a list of all of the service areas where we are currently the Medi-Cal Managed Care Plan. You can see on our network access, we just like to share a little bit of the numbers on that with regards to our primary care providers, the number of specialists that we're contracted with, federally qualified health centers, rural health centers, the hospitals, and then our CBAS and LTC providers also. Additionally, in 2024, at the beginning, there were new populations and new benefits that were rolled out by the Department of Healthcare Services. So the duly eligible special needs population, or the DSNP, intermediate care facilities, and the developmentally disabled were added. Justice involved population, which is a huge part of the new CalAIM program. And then the undocumented immigrants also for the ages of 26 to 49 who also rolled into the Medi-Cal population. And then new benefits included dyadic care, community health workers, the doula benefit, and then additionally the street medicine benefit. So we cover all of the required essential Medi-Cal benefits. So everything from, there's 10 essential benefits, from primary care to hospitalization to lab visits to radiology visits. But in addition to that, also, we like to share that we've got additional benefits that we offer to our Anthem Medi-Cal members. So expanded telehealth programs. So utilization through our Live Health online telehealth program, which is urgent care 24/7, and then also includes a behavioral health component to it and a maternal health component also. Our Sydney Health mobile app, where individuals can go and access a variety of the Anthem administrative services directly from a mobile app versus if they're going out to the website. Additionally, one of the many new benefits, and Eric will speak to some of this, is connecting our members with housing support services, addressing food insecurity, helping them with jobs, helping them with education, legal aid. There's just so much more now that we're more than just a health plan, is what we like to say. It's more than just going to a doctor visit or having a hospital visit, but it's really treating the individual holistically and addressing all of those necessary needs that play into their healthcare and their wellness services. So doula services, spoke to that. We do offer ride services, transportation, a 24/7 nurse line, interpreters and translation services, health education classes and materials. We have a new baby, new life program for our new moms, and pregnant members. And then a robust care management and case management departments and support services that really look to support those members who have chronic conditions or specific disease-related conditions. And then our special programs team, which really focuses on the CalAIM benefits of the ECM services and the community support services. So with that, I will turn it over to Eric and let him jump into our special programs and services and CalAIM services. Eric? I thought I saw him.
I'm here.
Online.
Hello, can you hear me?
Okay. Yes.
Oh, good. Okay. Sorry, everybody. I'm having a little trouble with the app, and that's why I'm not able to share. It crashed 3 times trying to share my my picture. Janet, can you continue to share it? Okay. All right. So can you move to the next slide? All right. So I'm going to start here with CalAIM. So I didn't, I'm sorry, because of my app instability, I didn't introduce myself and I didn't hear any of the introductions. So I'm sorry, I'm speaking to an audience that I'm not familiar with, but I'll just briefly introduce myself. I'm Eric Schwimmer. I'm the program director for Enhanced Care Management here at Anthem Blue Cross. I do see some familiar names. Baljit, nice to see you again. Thanks for organizing this. I'll start with a little bit of background on CalAIM, and then we'll talk about enhanced care management and some of the complementary services that we're offering under CalAIM. So CalAIM, just real high level. I mean, new programs, as I mentioned, structural changes, payment reform, affects managed care plans, affects behavioral health departments. It's a really big sweeping Medi-Cal reform package. And what's most exciting, and I think what kind of the theme that something I really want to highlight today with, where we're going with enhanced care management and some of these other programs is that it's helping to enable this sort of cross-sector coordination like we've never been able to do before. It's a real challenge. It's going to continue to be a challenge, but I think it's something that, ECM is a strategy to help address. And this is really key, I think, to moving us as a safety net, right? All of our multiple systems of care, moving us towards a more, just and equitable healthcare system. So that's where I'm going to leave that one. Can you move to the next slide, please? All right, so focusing on enhanced care management. So enhanced care management, the way DHCS designed it is kind of like a pyramid where we have sort of basic services and basic care management at the bottom that applies to all members, regardless of your sort of clinical need. But sometimes there's a need for some sort of light care coordination. It's entirely telephonic. Then there's complex care management or case management, and this is for folks who are basically stable but have an acute urgent need that needs to be addressed, and they need support from the managed care plan. That's also telephonic. And then there's enhanced care management. Also, I'll mention that complex care management is staffed by Anthem, whereas for enhanced care management, DHCS has really designed this for us to implement this through community-based organizations, and it's meant for that highest risk, highest tier population between 1% and 3% of the Medi-Cal membership. So I believe Janet mentioned that we have 1.3 million members. So that's about 13,000 members or so that we expect, or at least 13,000 members or so that we expect to be eligible for this program. And it is, it's community based, and the theory behind that is that's where the engagement happens. That's where the relationships are. Right. It's not something that we can do from a desk or from the office in Woodland Hills or in Sacramento. It's something that you have to be out in the field to properly engage and build those relationships of trust and understand comprehensively or holistically our members and connect them to the services and supports that they need. So there's 7 enhanced care management comes with 7 required core services. And the first one is really key. Actually, DHCS, didn't include it as a core service, and the managed care plans lobbied to include it as a core service: outreach. So ideally, this is where the community-based ECM provider is leveraging their base, leveraging that community basis, building those relationships with potential referral partners, engaging Anthem members, engaging managed care members, identifying who's eligible for or who might be eligible for one of the 10 populations of focus that I'll talk about, I think, on the next slide, and referring those members to the managed care plan. So that's the ideal scenario. DHCS really wants us, and we really want to build towards that vision of a community-based, bottom-up referral process. In the foster care population of focus, or the child welfare population of focus, we do have some ability to proactively identify those members using aid codes that the state sends us, but we don't have a great experience or great sort of success rate engaging our foster care members through proactive identification, because it's essentially, it means, passing those down to providers, and it essentially means a cold call. And, people aren't familiar with CalAIM, they don't understand the value, they don't know who this person is calling. So all those things make cold calling, kind of a difficult engagement strategy. They also call out, DHCS also calls out that they expect referrals to come from county welfare departments, public health nurses, the folks that are serving the foster care kids in a healthcare context. Hopefully we can work together, over the next few years to develop those relationships and referral processes. So the second core service here is assessment and care planning. This is where we identify, the ECM provider identifies the member's needs, articulates their needs and goals. That's both clinical and non-clinical needs. And it should be, these sort of needs, this assessment is cross-sector by nature. We're talking about physical health, behavioral health, and SUD, even LTSS, oral health, social supports. This is the idea is it should be person-centered, and the goals should be informed by the member. So I think for the foster care population to focus, it's the children enrolled in California wraparound or healthcare program for children foster care. The DHCS expects the managed care plans to be working closely with those programs, and leveraging leveraging those existing care plans that that already exist. There are already goals. There's already some thought around that cross sector or multi-system work. So we'd like to work with the county welfare departments on that. So the next core service here is enhanced coordination of care. So this is essentially implementing the care plan that's connecting the member to the primary care provider, which is really key, big emphasis of the program. Developing the care team, aligning informal supports, the natural supports, the friends and family, and communicating the members' needs and goals with all the parties, the whole care team. Aligning and integrating the needs and demands of different systems of care. That's a really key sort of contribution or value that I think enhanced care management can do. For lack of structures, right, to coordinate, it's the enhanced care manager, or I'm sorry, it's the lead care manager who is able to to bridge those different silos, those different systems of care, and align and integrate and coordinate on behalf of the member. And also supporting the member through their treatment, attending appointments, medication adherence, arranging transportation, all the basic things that you would expect that a care manager might do. The next core service is health promotion. So this is when we work on, kind of building those family and social supports. This is where coaching and life skills come in, and we've got some community supports that are focused on that as well, and we'll get to that on a future slide. And generally linking members to healthcare resources. Transitional care services. That's core service number 5 here. So traditional care services is tracking the members' admits and discharges from institutional settings, hospitals, nursing facilities, mostly hospitals, right? Making sure that they have or can access the hospital's discharge risk assessments and planning documents, and communicate those documents to the rest of the care team. They're responsible for, during that transition period, for making sure that those planning documents are getting implemented, that they're following up on all the appointments and tasks that might be key to keeping that member from going back into the hospital. Family supports, the next one, member and family supports. This is, really high level, just educating and engaging and supporting the members and their natural supports. And this also ties into to some support services that we offer, community supports. How do we support those caregivers to do their job? So we'll talk about that in a little bit. And then the last one here is community supports coordination. So, this is community-based services. This is community supports in the capital C, capital S sense that are the managed care plans are responsible for under CalAIM. The idea here is that we're not just looking at a member's healthcare needs. We're also looking at their their unmet social needs. And we're, looking for those emerging social risks, coordinating between the different support services, making sure that, it's not just a referral, but the member is actually getting those services. So kind of closing the loop. So that's basically enhanced care management. Can we move to the next slide, please, Janet? All right, so there are, I don't think we're looking at the very bottom of the slide there, but there's roughly 10 populations of focus. There we go. 10 populations of focus. Yep, you got it. And I'll walk through these briefly. So we've got individuals experiencing homelessness that's divided between adults and children. You can see here in this grid, right? All these populations, or most of these populations of focus, have an adult version and a child and youth version, and the eligibility criteria are similar, but there's a lower bar for children and youth generally. So there's two versions of the homelessness population of focus, one for adults with dependent children and one for homeless families. And then there's a child, a kind of unaccompanied youth population of focus there. There's the avoidable hospital or ED utilization, formerly called high utilizers, child and youth focus, individuals with serious mental health. I'll show you some numbers on these in a little bit, or SUD needs. I'd say we have a pretty strong program on mental health. We have not developed a strong program yet around SUD. Individuals transitioning from incarceration, as Janet mentioned, this is emerging. We're going live on 10/1 with pre-release services in we think just 2 of our 16 counties. Adults living in the community are at risk of LTC. I'm not going to go over those because they're not child focused. We'll talk about that in the afternoon. Children enrolled in CCS with additional needs, and children involved in child welfare. That's the foster care population, and birth equity, which is basically, the criteria there is the member is pregnant and meets race criteria, which is Black, American Indian, or Alaska Native, or Pacific Islander. I'm sorry, did I hear someone trying to ask a question? No, okay. The idea here, I'm going to focus just for a second on the birth equity. That is, I think we're going to talk about these numbers too, but this is something that I think is worth sort of pausing on, because it's a new population of focus. It was restructured from other populations of focus that existed before in a previous version of this. There's organizations that we need to develop relationships with in order to effectively identify folks and coordinate. That's the Comprehensive Perinatal Services Program, Black Infant Health, California Perinatal Equity Initiative. There's stakeholders there that we don't have strong relationships yet with, and I know that they're connected to counties. So love those sort of relationship building opportunities to be part of our conversation. All right, next slide, please.
Just to step in for a second, Eric, we do have a couple of questions in the chat. And so I didn't know if you wanted to do questions as they come up, or you wanted to wait until the Q&A period.
Yeah, let's do it. I'd rather this be a conversation than a one-way. So let's look at the questions in the chat. I can't see them. Would you mind reading them, Baljit?
Yeah, no worries. So from Dr. Lau in LA County, first question he has is, how many children lives are covered by Anthem in California?
I don't have an answer for that. I could tell you ECM, but I don't know how many children are covered in Medi-Cal.
I can pull that number for you and send that over, or I can try and see if I can do a breakdown by counties and get that over to you. I don't have it at my fingertips, but we can find it.
Great, thank you.
Thanks,
and
Janet.
then the second question is it possible to get child-specific community supports for our county? And that's from Dr. Lau in LA County as well.
Child-specific community supports. There are 14 community supports, and a lot of them are applicable to children. And we'll talk about that a bit on a near future slide here.
And I replied also that we can share, we're great. We'd be happy to share a list of those community supports by county.
Oh, okay. I misunderstood the question. Thanks, Selena.
Mhm.
Okay, and then I have some more questions from Dr. Nguyen, CWDA. Do you have a caseload size for ECM, and what would that be?
We have a max, and our max is 50 ECM enrollees to a lead care manager. We know that's a lot, and we don't recommend that people hit the max. And we encourage providers to have a more intensive caseload, or so I should say, fewer members per each lead care manager. But given the rates, we wanted to give organizations flexibility with their models, to have up to 50 if that's appropriate for their model and that population of focus in their county, and given the local circumstances.
Right, thank you. And then another question around while youth are automatically eligible for ECM, will some be left on complex care management, and who makes that decision?
So youth aren't automatically eligible. I mean, it's a benefit. And if we can identify, I think one big challenge we have with ECM is identifying eligible members. For lack of data, sort of knowledge and education, sort of familiarity with ECM in the community, we know that there's a lot of folks out there who are eligible, but we're not identifying. So that they every member has to go through a kind of a screening process, a referral process where their eligibility is checked. So it's not guaranteed that they're eligible.
Yeah, just to clarify, I think we meant foster youth under
Okay.
the population of focus. And so again,
Okay.
if they're automatically eligible for ECM, yet we have that complex care management service as well that Anthem provides, how do you determine which one gets, what level of service, and who makes that decision?
If the member is eligible for ECM,
Okay. And then
thank you. If the member is eligible for ECM, then it's an entitlement. They have a right to ECM. If they prefer, we can recommend, or the ECM provider, if they feel like they meet the graduation criteria, there's a whole process for that, and then it can be graduated to a lower level of care.
Okay, and then you mentioned earlier about TCS service, and the coverage for that
Yes.
includes institutions, hospitals, admissions, discharge, etc. Are STRTPs, which are residential treatment facilities that child welfare programs do utilize with foster youth, are those covered under TCS as well?
I am not familiar with STRTPs, but that sounds like something that would be a good discussion for the future. I think one challenge will be knowing when those admits or discharges happen. If we could figure that out, if that could be, we could figure out how to communicate around that. That would be ideal.
Okay, then last question from Dr. Nguyen, and then I'll let you continue on with your presentation, and we'll get to some more questions later. But actually, I'm going to wait for that question because it's more around becoming a provider. So I'll wait on that question.
Oh, good. Okay. I wasn't sure if we wanted to talk about today, but we'd love to talk about, becoming a provider. I mean, I think one kind of takeaway from our meeting today, I hope, is that, we want to work with you as providers potentially, but as referral partners first and foremost, and as care coordination partners. We basically, know we need to work with you to make the system work for our members, and hopefully you can see that the same way. And if you become providers, then that's icing on the cake. All right, yeah. So this slide here multiple systems of care. To me, this is the most important slide, in the deck. I mean, it kind of, illustrates here, for a, say a foster care youth, different systems, different systems that they may have a foot in, and how complex it could be, for any particular person to navigate, these different systems and different requirements. And so it kind of highlights, the importance of having a single point of contact, right? And that's the vision for lead, for a lead care manager for the ECM program. And it highlights the importance here of one thing I think we need to emphasize is that, DHCS specifically says, this does not replace, existing foster care programs, even though there's a care management component to it. DHCS considers these to be ECM to be complementary. So I mentioned earlier when we're talking about the care plan, the assessment and care plan, that's already been done to some extent, right? That were under existing programs, a healthcare program for foster kids. That's they would expect the ECM provider to be in contact with that person as a key member of the care team, and to leverage the existing care plan as they develop, as they add on to it, right? They might be considering other systems of care here that the foster care health plan is not considered. Where this could be, a public health nurse could also be a lead care manager. They're the ultimate in integration there, right? They could have their care plan based on the healthcare program criteria, and then they can enhance that with the ECM program and get paid for those services. So we can come back to that, potential provider conversation later. All right, we can move to, I think we skipped the next slide because that's focused on the adults. So we can move to the slide after that. Okay, so here's some figures. I thought this would be interesting. I know we're talking to folks from different counties today. On the table on the left, we're looking at the number of enrollees and the number of providers serving those enrollees by child population of focus. And the table on the right, we've got the number of providers we have serving our child population of focus, children populations of focus in each county, number of providers. So I think, a couple of highlights here. One, birth equity is relatively new, and I think I'd mentioned that we don't have great relationships. We don't have relationships with those sort of key birth equity stakeholders yet. So we're working on that. So our enrollment there is low because we're really not getting referrals from those providers in any substantial numbers yet. Also low, something that we really need to work on is CCS and child welfare. You can see how low those are. And hopefully, through this discussion and future discussions, we can highlight, sort of highlight the need here and work on a collaborative approach to addressing the needs of these kids. JI down below is 0. We're not serving any members in that area yet. I think there's a lot of sensitive data, a lot of concern about sharing that data. So we haven't received any referrals yet for that population of focus. And when we do, it'll be coming from, corrections facilities, juvenile detention facilities, at least in the beginning, almost exclusively. So those are the things I wanted to highlight there. Happy to take any questions, or we can move to the next slide.
Yeah, if I could ask the provider question then now. So if a CWS agency or department wants to become an ECM provider, under the child welfare population of focus, we have 5 categories. Would they would they have to become a provider for all 5 categories under the child welfare population of focus, or could they select 1 or 2, 3, whichever ones they want to out of the 5?
Oh, there's different programs that are cited there, right? Is that what you're referring to? No, it's all you'd be a population. You would serve all of those.
Okay.
Potentially, yeah. But I mean, you would be leveraging your base, right? So, if you work in one program or another program, you would be using, you'd be making referrals based on that program. It's possible we get a referral from an outside entity. It turns out that they're, foster care, eligible for the foster care population of focus, that we would work with you. We would assign that member. We could assign that member to you as a provider. If it's not your specialty, you might have a recommendation on, where a more appropriate provider, if there's a more appropriate provider, or you could help us work with them. The basic ECM, sort of methodology or core services are the same for all populations of focus. But that's something that we can talk about, and assigning members to a provider is something that's not negotiable is not the right word, but you can say this isn't appropriate for us. Here's a different suggestion.
Thank you. Yeah, if you want to continue on with the presentation.
Sure. Okay. So we have a no wrong door policy on making referrals. So our members can call, a provider can call, an ECM provider, the county can call, anybody can call to make a referral through customer care. When a referral does come through customer care, it has to go through a triage process. So it takes a little bit longer than sending a referral form. So what we'd like to get with the folks on this call is a sort of familiarity at some point with the referral form and all the criteria, so that you can send that referral form directly to the ECM program and bypass that triage process. So that's pretty much it. And if you're an ECM provider, you can also, we have a special portal, and that's sort of a fast track for making those referrals. We assume that those ECM providers know those criteria in and out, so it requires less review. And I think another, good strategy for making a referral, is reaching out to a local ECM provider. That's if we publish our provider directory, you can see who serves the child welfare population of focus, or all the child populations of focus. And if you think someone might be eligible for a particular population of focus, you can work with that provider to basically go through the referral criteria, and then that provider can make the referral to us. So that's what I'd like to highlight here. Next slide, please. All right, so community supports. Community supports they complement. You don't have to be an ECM to receive community supports. These are available to all of our members. It's not technically a benefit, but it is. We believe that that's where DHCS is going, and this is the direction we're going. We've adopted all 14 community supports, although they're technically optional, but we are providing all 14 in all of our counties. And I think they, another way to bucket them, we've got some buckets on the right here that, is helpful. And another way to bucket them and kind of explain where these community supports are is there's like a bucket that are sort of primarily focused on individuals experiencing homelessness. So, that's the housing suite of community supports. That's housing navigation, housing deposits, housing tenancy and sustaining services, to keep those people, keep their rent paid. And then there's day habilitation, which is like, sort of life skills and coaching. Then there's short-term post-hospitalization, which is it's really targeted towards our members experiencing homelessness. It's up to 6 months, and it's kind of a staging ground, if I understand it, to get set up for the next level of supports. And then there's recuperative care, which is more medically intensive, more medically focused. And there's a limit of 90 days for members who are transitioning from a hospital or potentially a nursing facility, and use that recuperative care community support. So that's the first one. That supports to get people housed or experiencing homelessness. The next one is supports to keep people at home. So they are housed. How do we keep them there and stable? So that's respite care, which is support for the caregivers. It's personal care and homemaker services, which you might think it's mostly adults, but there's lots of kids in LTS and IHSS as well. And it's very similar to IHSS. It's complemented, does not replace IHSS. There is There's environmental accessibility, which is, things like an air conditioner or a door or a ramp or grab bars in the home to make sure that the place is livable, for folks with physical impairments. Nursing facility transition and community transition services, probably not applicable to the kids, so I won't go over those ones right now. All right, and there's a couple of community supports that are sort of focused on managing members, helping members to manage their chronic conditions. It can be any age, so we've got medically tailored meals and asthma remediation. And then there's one more, I think I mentioned all 13 of the 14. The last one is, support for our members who are recovering from acute intoxication. So, they may be picked up by law enforcement or safety officials, and this is a diversion from jail or ER. They may end up there. This could include kids. All right, so next slide, please.
Can I ask
Oh, yeah.
a couple of questions about community supports for my own understanding as I lean into this for counties? In particular, the respite services in the policy guide, it does call out foster care beneficiaries as eligible. Can you talk to us about how you envision that service being utilized for foster youth?
So if Selena, if you wanted to take this one, that would be great.
Sure, I can jump in here. Thank you, Eric, and thank you, Baljeet, for the question. So as long as the member is covered with Anthem Medi-Cal and they are enrolled in respite care services, then their caregiver, whether that be a foster parent, a biological parent, whomever their caregiver might be, will be eligible for the respite services here. So again, as long as the member is participating in these community supports, in respite care services, then definitely the caregiver is eligible for that as well.
And just to ask another clarifying question, so would the person providing that respite services, would it be the responsibility of the child welfare department, the foster parent, to find that provider, or is it that Anthem has a list of providers that could be utilized?
Great question. So we have potentially both options. We have a list of contracted providers for respite services that come with a group of, or sort of a network of, respite care providers already, available. We are also contracted with other organizations providing respite care services that will work with the family, if that's preferred, in identifying another caregiver, perhaps a different family member, another foster care parent, that can help fulfill that role as well. So we have both options available. Again, a network of available respite care providers, as well as organizations that will work with that caregiver to identify another respite care person to assist, if that's the preferred way.
Great, thank you.
Mm-hmm.
All right. So a couple of other complementary programs, they do not duplicate ECM. They can be, we do have to be careful about that. Actually, CHW services can overlap with ECM, but can also be complementary. So the community health worker services, this is an individual who speaks the language, who basically is there to help a member who has trouble accessing the healthcare system due to cultural or language barriers. They help with that navigation. They provide education, health navigation, screening and assessment, individual support or advocacy, and asthma preventive services. So that's a new program for us. Community health workers, also a CalAIM program, and then doulas. So our doula benefit provides visits to an expecting mother, both pre and postpartum. There's an extended visit for postpartum visit, a 3-hour visit. that's allowed, and they provide support during labor and delivery, and they basically are there to provide guidance, help navigate the system, create a birth plan, linked to community resources. Okay, next slide, please. And I have these slides in here. I'll treat them lightly unless there's questions. But it sounds like there's some interest in, how do we become an ECM provider? So this is, sort of roughly the process. That starts with submitting a letter of interest, and then there's a certification process where we basically look at your bona fides, determine that you are actually an expert in the subject, expert in the population of focus that you intend to serve. And then there's a contracting process. Next slide, please. And I'll highlight here that our different CalAIM programs have different payment structures. So ECM is there's a one-time rate for outreach, and then there's a per member per month, a PMPM rate for monthly care coordination. And then there's different structures for our community support. So that's highlighted here as well. So in some cases, there's a fee-for-service structure. You get paid for every claim that you submit, every service that you provide. And then in some cases, there's a reimbursement method where you actually, you as a community support provider, that community support provider has to, basically front the money and then gets reimbursed for that cost. All right, next slide, please. I'll just highlight this as well. We're working on our quality program with ECM. It's a very new program. These are the metrics that we're looking at they're all process metrics for our ECM providers. And we would love to have a conversation about what sort of outcome metrics look like and how we could build that into our value-based program in the future. And I think that's it. I've got a resources tab here, and happy to take any other questions.
My thought was that seeing that we're already at 10:55, that we could continue on with your presentation. I think you had mentioned the MOU, the process around that in the beginning, and the CWS liaison.
Sure. So, Jared, are you out there? Do you want to touch on the MOU process?
I am, absolutely. Janet,
I'll turn it over to you.
I'll ask you to stop sharing and see if I can share. I have a simple one slide for everybody, because I think based on the attendees here, you either have to already hear me asking 1,000,001 questions, or you see my floating head on a Word document asking 1,000,001 questions. So I apologize to the Barbaras and the Leslies, the Michelles, the Kathys, the Anns out there who have to deal with me on a consistent basis.
All right, I stopped sharing. So can you've got it?
Potentially. Let's see here.
Okay. While you're sharing, I think there was a question. So on the residential treatment centers, and I saw that come up more in the chat too. So where we're at with the residential treatment centers. So, for mental health services, it's a split benefit, or it's a bifurcated benefit. So the county mental health departments handle the specialty mental health services, and then the managed care plans are responsible for the mild to moderate conditions. And so there is care coordination that goes on between the county behavioral health departments and the managed care plans, because we know that, a member maybe today, a specialty mental health condition might have a crisis, and then they hop over to the county, or we're managing them also on the mild to moderate side of things. So on the actual residential treatment programs right now, it's a benefit that is covered underneath the county behavioral health department, with the exception of that there are physical health components being provided within that residential treatment facility. And then that is where the managed care plans are responsible. As far as how that falls into ECM and CalAIM, we probably would want to have more conversations on that and include our behavioral health director. But at this point, it's, because it's specialty mental health, it falls under the direction of the county behavioral health department. So I hope that helps in answering that question.
Yeah, Janet, this is Lachlan from CWDA. Thank you for that.
Welcome.
And if this is more rhetorical, but it's somewhat similar to if they are in an acute psychiatric hospital, et cetera. I think my question was focused on the transitional care services portion of it. I do understand that county behavioral health through there's behavioral health information notice 22017 that talks about concurrent review, et cetera, how they have to handle aftercare and things of that nature from a discharge. But again, this is, while they're in either an acute psychiatric hospital or an STRTP, there is the discharge component of it as they're leaving. So that was more my general question for sort of future discussion and your consideration, not so much to put you on the spot. But thank you for that.
Great. Yeah, no, that's helpful. And that's something too that we can take a look at and have further conversations on, most definitely. Thank you.
Well, perfect. Hopefully everyone can see my screen. Thumbs up. My audio is working also. Confirmation. Thank you very much, Laura. I appreciate that. So, Jared Martin, I am a program director reporting to Janet Payne on her county account management team. I alluded to the fact that you probably have either seen my face on a Word doc or you've heard my voice once or twice in our meetings around our MOU negotiations and reviews currently. I think at this point in time, we've met with the majority of our county partner agencies with all of the MCPs throughout the counties, and at least in early conversations around the MOUs. So I just wanted to touch on that very briefly, just to say that I think collectively throughout the state and within Anthem service area, we're still in the process of just reviewing the most recent revisions, the proposed revisions from CWDA, and negotiating between child welfare and the MCPs about the additions and revisions that are currently being proposed. So I think that's where we currently are. I did put in here some future considerations that I think what we need to look forward to as we continue these conversations. For those of you who aren't necessarily part of those conversations and negotiations, is of course around one of the biggest hot topics is data exchange, right? How are we going to exchange data? What data elements are we going to exchange? What capabilities do you even have with your system? What can you ingest? Do you have the bandwidth? Sorry, Leslie, I'm going to pick on you because I know in our rural counties that you don't necessarily have the staff to pull data. So these are things that we're going to have to look at and explore on a case-by-case, county-to-county basis on how we can all work together to figure out how we can communicate and exchange the data that we need to do to satisfy these MOUs, but also to make sure that we're assisting these children and youth and our members for the greater good, right? Ultimately. So it's going to be a work in progress. We're going to have to take a phased in approach as we continue through these conversations. There's just not a one-size solution that fits all currently today, right? But I think as we work together, we partner and we iterate, I think eventually we will have a great model utilizing health information exchanges, QHIO, so Qualified Health Information Organizations, and a bunch of other acronyms I won't even exchange at this point in time. But also I wanted to call out too, as far as considerations go, there's a lot of conversation in the MOUs around the MCPs participating in your AB 2083 or your system of care MOUs, which Anthem is in particular a huge proponent of. We absolutely want to participate in those conversations. Michelle and Swami has been kind enough to invite us to the table to participate in those conversations. And it's been a very educational experience and opportunity. I would just ask that we start to think about how the MCPs can fit into those meetings. Do you want us to be part of the ILT? Do you want us to attend committees as the advisory board? Do you want us to just do presentations? Thinking about how you want us to fit into those processes is crucial because there's a lot of language in the MOUs around that, but it's not clear today how we can truly participate and partner in those processes. So I just wanted to call to everyone's attention those key points here. I've said a lot of words, so I'll stop talking and I will open it up for questions, comments, and concerns at this point.
So I know we did have a question in the chat about the MOU, and I'm trying to find it real quick.
I saw that about the county probation departments.
Yeah, our managed
So-
care plan's supposed to sign MOU with county probation departments.
So DHCS has an MOU website that lists all the different MOUs that we're supposed to have. And at one point in time, it did list county departments on there, but there's been some revisions to that website. There's been some revisions to the MOUs that the MCPs are supposed to have in place going into 2025. I've reached out to DHCS for further information, and additional guidance is forthcoming, but we do anticipate that any justice involved department related MOUs are still expected for 2025. So I can drop that link to DHCS's MOU website in the chat, so that way everyone can be aware of what MOUs do exist currently and what MOUs are expected in the future.
Yeah, and I think the reason why it does come up is because they also have foster youth and probation youth that end up in placement. And so while the Justice Involved initiative captures quite a large group of those involved in probation and, you know, incarcerated, there is a fear that they don't really capture all the foster youth on the probation side. And so we have raised that up to DHCS, but yeah.
Well, wherever we can fit in to help to advocate and also to participate, please count us in.
You know, and just to add to that also, I will say, you know, we're partnering with some of the school districts and the County Office of Education as a piece of the Student Behavioral Health Incentive Program that was launched 2 years ago, and it's phasing out at the end of this year, but then will be covered by the CYBHI, or the Children's Youth and Behavioral Health Initiative. Some of our County Office of Education's actually utilized some of that SB HIP funding to enhance some of their programs that they have with the schools or at the school districts that revolve around youth that are in some type of a continuation school, or maybe there is a continuation program or a justice involved program that the schools help to oversee. And so we've actually been having conversations with them also in regards to, you know, how can we capture, you know, the individuals that maybe they are in foster care, and so we are missing them because they're receiving services from someplace else. And so really having that conversation with them also in terms of making sure that they're sharing that information with us, and that we are being able to, you know, share information and have that data sharing capability on those individuals so that we can get them into the necessary care that they need to have. And I think the other one too to mention is the first fives. And so there's, you know, we're expected to have MOUs with all of the first fives in the counties. And so, you know, we're talking with first five with regards to how that's going to work and how we'll be able to share data with them also. So lots of conversations going on.
Yeah. Another question just came in around the MOU. So with regard to data sharing, how is Anthem currently capturing youth referred from or involved with child welfare?
So I don't want to step on Eric or Selena's toes, but for referral related purposes, right? We have fax, secure email probably coming in with the referral forms and any supporting documentation to support those referrals for our CalAIM services of the ECMCS, for our care management processes too, similar process, email and also secure email and fax as well. Now we also have processes set up where we have STP, SFTP data connections, secure file transfer protocol connections set up with some of our partners. We're expanding that process. Absolutely glad to start those conversations with anyone on this call if you're interested, but I don't know that we're there yet necessarily. But that would be one method, one channel where we can start connecting a bidirectional exchange using SFTP to provide certain file types. I know Eric's been a champion behind communicating and exchanging 834 and 837 files tied to like utilization, demographic related data.
Yeah, hey, let me just add on real quick to that. Thanks, Jared. I think ideally, we'd like to exchange population files. I think there's value in that. There certainly has been for other departments, but if you knew who our members were and who their PCPs are, right, that could help you do some coordination that perhaps, that can enable some coordination that's currently not happening or not happening to the extent that it could be. And vice versa, if you could send us data on who your foster care members are, then we can connect them more proactively to support services, the community supports in ECM.
Justin, you have your hand raised.
Yeah, it might be easier just for me to talk. Hello, everybody. My name is Justin Johnson. I'm the Cal-AIM Division Chief for Implementation for Fresno County. My question was really specific to, at present, we don't have the signed MOU between us and the managed care plans as far as creating a dedicated pathway for foster youth so that you guys know they're coming from us. We're always in that care coordination mode. So I'm really asking, as of right now, if we have children that we are referring through the ECM process, how do we know and communicate with each other? How would you know that that child is part of child welfare as just opposed to just a member that's requiring a service from you?
You would state that would be clear from the referral form that you send. You would check the box that says they belong to this population of focus, child welfare population of focus. You would add your contact information there as well, provide any other details that you think are relevant to the referral, and we can follow up with you.
Okay, thank you.
So I know we have more questions that are coming through the chat, and then they're being privately messaged to either myself or Andrea. So I just want to give Anthem a chance to finish their presentation before we get into the Q&A portion.
Well, not much more from me on this point, but in the MOUs, there's exhibits A and B for each of the MOUs, and it calls out responsible parties and liaisons for both the managed care plans and also our county partners. So one liaison is now the MCP child welfare liaison, formerly the foster care liaison. And for Anthem Blue Cross, that is me. I am the non-clinical component for the child welfare liaison. I just want to make that abundantly clear. So there is a clinical component to this tandem relationship here. She wasn't able to join us today, unfortunately. But I can drop in our child welfare email inbox if that would be helpful for you all. But ultimately, as we move to execute those MOUs, you'll have that email inbox, you'll have that contact information as part of the execution process.
Great, thank you. So we can stop sharing the screen if that's okay. So we can see everyone, and we'll move into the Q&A. We do have a couple of questions in chat. I'm going to allow folks to raise their hands, and we'll monitor that and then let you ask your question directly. And so I think I did see one hand raised real quick, but I think it went down. Dr. Lau, do you want to ask your questions?
Sure. Hi, thank you for the presentation. What are Anthem's thoughts about reaching the family maintenance population? My understanding is that there are no aid codes to identify the family maintenance population, and I think that the family maintenance population would particularly benefit from ECM.
I think that's right. This is Eric. I don't think, I know we've got some foster care aid codes. I don't think, the family maintenance program is definitely, one of the eligible categories in that population of focus, and we don't have a good way from the data to identify who those folks are. So that's, that kind of, to me, that means we really need those relationships with those, family maintenance program stakeholders in order to figure out how we, coordinate and get those referrals in. So I appreciate your interest.
And then Dr. Lau, did you have other questions?
I think you answered it already in the chat. Thank you.
Okay. And then I do see the hands raised, and I apologize. I'm going to go to Andrea first real quick to talk about several questions came into her around prevention and that landscape that's happening across the state.
Yeah, I'm happy to I dropped the question to chat, and I'll actually pass it on over to Derek, who inspired the question. But really, it is around the child welfare involvement and how does Anthem define that as a benefit for ECM, because we are stretching into the prevention space and are seeing children who are not yet involved in child welfare trying to head out. And so we were wondering, how does ECM come to play there? But Derek, I'll turn it over to you to ask follow-up questions.
Yeah, I think it's exactly that. Thanks, Andrea. And so I've been working with the state and counties to help roll out the Family First Prevention Services program, and knowing that families might be entering to receive prevention services as it relates to them as they're maybe as imminent risk of entering foster care, but they are considered candidates for foster care. So looking at the criteria on the referral for Anthem, I just wanted to check in to see where would that population fit in within this, if at all, if they're eligible for ECM specifically.
So I'm not sure I can answer that question now. I mean, I'll take a look at it. If you could send me some details, I'm not familiar with that program. If they're not in foster care, but just eligible for foster care, I don't know if they meet the criteria strictly, but I can say that we do have discretion. Like if there is someone who we think could benefit from this service, even if they don't meet the strict criteria, we can make exceptions to the criteria to include a member in the program. So that might be a sort of case by case kind of thing, rather than having a sort of a blanket policy. But we can discuss that more. If you can send me some details, I'd love to see it.
Great, thanks, Eric. I can do that because I do see that there are some where it does indicate if they've been involved in family maintenance, and so within the past 12 months of being eligible. And so that, along with some of these other eligibility criteria, I could see there being some nuances to this candidacy and eligibility for ECM. But knowing if families don't fall within any of those pieces, knowing that families could be candidates for foster care but not meet any of those other requirements, might be worth exploring how they might fit into this as well. So I'll work with Andrea to send over some materials to share. Thank you.
Thank you. And then Michelle, I know you had a couple of questions.
I do, thank you. So one of the things I've noticed throughout the MOUs is that there's like a lot of policy development that's going to come into play, and that's a worry for me just because of staffing and the ability to do that. And I was wondering, will Anthem have those policies developed for like review and input, or is that going to be something that will be put on the counties to do?
So Michelle, the goal would be to work collaboratively to co-develop those PMPs, right? So that way both parties have the ability to provide that input.
Jared, do you guys already have something in the works by chance? I mean, because I know like
we do have certain things, right? So we have to have policies in place based on all the APLs, the all plan letters that DHCS prescribes to us. So any of those components that would be listed in APL has supporting policy and procedure for that. So there would be PMPs in place. It's just about crafting those PMPs that would be appropriate for these circumstances based on those requirements, right? So we'd have to talk about, like, I'm going to pick on data because it's an easy topic, and the specifics of the data that we're exchanging and the timeliness of those data exchanges are specific PMP requirements of the MOU, right? So we would have to define what that looks like from our relationship, right? And it could vary between Tuolumne County to Sacramento County, right?
And that makes sense. I just, starting from the ground up on like numerous policies was a worry for me. And so I just was hoping there would be something that we could like work off of. And then also my second question was, is I've noticed that there's also this closed referral loop, the closed referral loop mechanisms that I think Cal-AIM, will be going live with January 1st is what I thought I had seen somewhere. And so Colony County is actually implementing one, and I didn't know if that was going to be acceptable. And then also, would there ever be any kind of financial support to kind of help that keep going, because they do cost money?
So the closed loop referral requirement is stated as optional language in the MOU with a January 1st, 2025 launch date for CalAIM related services, so ECMCS, right? And we're anticipating DHES guidance on what that's to look like, but we have yet to receive said guidance. So I'll leave it at that statement. Anthem does not use Unite Us. We use Find Help, which is a competing platform. And we haven't figured out a way to figure out how those two platforms can communicate at this point in time necessarily. I know that, be very cautious with my next statement here. Anthem at one point in time did provide funding to Tuolumne County that was used for the purpose of Unite Us. So we can absolutely look into what other financial opportunities are out there to support platforms. We don't necessarily have anything to say concrete, but we would certainly say, if you have a need, present that need.
Okay, thank you.
Great, thank you. Anyone else with a question?
Baljeet, it's Leslie. I guess I wonder, going back to the data elements discussion, sometimes it feels to me like individual counties are, having to create the wheel separately when, all of our counties, all 58 of us are on CWS CMS with kind of the same, limitations on pulling data or what data we have. So I just wonder what statewide, what conversations are happening looking across the state at the data elements versus these individual discussions.
Yeah, so I can share a little bit in regards to our work that we've been doing with DHCS and CDSS on this, because that is a concern, right? And so CDSS is leaning into the data sharing and seeing what they could potentially provide. Andrea and I meet with the CDSS partners on a monthly basis to get an update on that. And so they are working on it. What exactly that is going to entail, we don't know at this time, unfortunately. Andrea, anything else you want to add to that?
No, but I think that is absolutely on their radar and something that we are asking about progress, and it seems like it's slow, but it's in play.
I think it would also be important, right? Because what I'd hate to see is, because we all have different levels of knowledge, right, about what can and can't be done out of CWS. So, I'd hate to see one county like El Dorado, for example, say, oh, we can't do that, right? But another county says, oh, no, we can do that. And how are we sharing information across counties about the how-to on certain things?
Yeah, so that's great feedback that we can provide back to CDSS and our meetings on this.
Yeah.
Definitely.
We know that an ACL is in the works, and so the component in that ACL could be a little bit more information about how to develop that data and share it. So really good input. Thank you, Leslie.
And there was a question in the chat around fiscal, and let me see if I can find it real quick. But just making sure that, if you are leaning into CalAIM, that it's not in conflict with other funding sources that you have at the county level. And so we will have a fiscal related webinar and training on this, and we're going to break it out where it's going to be one for child welfare related and one for adult and aging. And and really kind of leaning into, what are the opportunities through CalAIM, but also being mindful of, allocations and funding sources that you currently have as well, and how to look at potential blending and braiding opportunities there. So more to come out on that soon. All right. Well, we are coming up to 11:30 here, being mindful of everyone's time. Just want to give an opportunity for any last questions. One of the things that Dr. Nguyen and I have been really looking into around foster youth as they move from county to county and just the continuity of care. So I just want to give a moment to see if there are any questions around continuity of care. What are the roles and responsibilities when foster youth move from an Anthem county to a non-Anthem county? How is that going to play out? So I don't know if someone from Anthem wants to answer that a little bit more, or if there's a question in particular from a county where you want to highlight, a recent experience around that.
Yeah, so Baljeet, I can tell you, we're actually working on developing an FAQ sheet that hopefully will help with some of these questions. And that question has come up from some other counties. And that's something that we need to look into. We need to figure out, it'll be part of that foster care liaison role, the clinical and the administrative role, to, determine how that's going to function. And when they do move to county, because we know that that is a concern and that's an issue, especially if it's an Anthem member and then they go to a county that's a non-Anthem county, or Anthem's not the health plan, or even if it is a health plan, how do they change their PCP once they get over there, and how does this all work? Those are some of the details that we're trying internally. We've got an internal group that we're working through those and having those conversations on how we want to see that happen and make that transition as smooth as possible. So we've got a cross-functional team at the table, and we're having those conversations to say, how can we do that, or how can they get moved quickly? Where now it's like if they change a health plan, it takes 30 days, or if they change a PCP, it takes this amount of time. What can we do to help streamline that or make it seamless? So we are having we're having those conversations internally.
Great, thank you. And just for counties, another thing that Dr. Nguyen and I are also working on is really trying to understand the process of how foster youth get assigned to a managed care plan. And we've been having some discussion with some counties where there seems to be a systems block once youth come into foster care, that they're just automatically assigned to fee-for-service and they're not able to put them into a managed care plan. So I just want to see if that is an experience in the counties that are represented here, and if you have found a fix for that. If anyone wants to share. Oh, Dr. Liao?
I'll answer that question, but I also have another question. So if Anthem can talk about what happens in that sort of dead space when a child has been reassigned to another primary care provider because they have been replaced either within the county or to a different county. Here in Los Angeles, there's no documentation anywhere in terms of policy and procedure when it comes to assignment with fee-for-service Medi-Cal versus managed care plan Medi-Cal. When a child enters foster care, they are enrolled in managed care plan Medi-Cal, and all of our children's social workers put in a form to disenroll them from managed care plan to fee for service, and that's what all of our regional offices do, and it's going to be a really tough change to move our kids to managed care plan.
Yes, I know that's a question or a statement, but what I will say is that's what we have heard. from people we have talked to, the welfare departments we have talked to, we've heard that that's the process, is that as soon as they get put into a managed care plan, they disenroll into fee for service. And so that's something else that we're looking into, and we want to have that conversation to determine, the number one reason why do you disenroll them? Is it easier, or do you feel that it's easier versus having them in a managed care plan? And then that's the other thing we're trying to figure out also, is we're looking, when we get the eligibility lists from the state, where are those aid codes, so we know that we can target those individuals that are in the foster care system. Those are some of our internal systems that we're looking at also. I don't know if that answers your question or not.
So my question still remains about how to access care for those kids who have been reassigned to a different primary care provider because of a replacement, if they've moved from one resource parent to another one, like within county or even outside of county. So
I think that's where our case management team will come into play. So reaching out to the foster care liaison, and then working with our case management team or our ECM case managers to make sure that, they're continuing to receive the necessary services. But again, because this is new to us too, we're trying to figure that out. So we're putting our processes into place to make sure that we've got that, for a smooth process also.
This is Eric. I might just add, when you're selecting a PCP, it's a relatively simple, it's a phone call to our call center, say I need to change my PCP. So it's there is a process for that, and it's pretty straightforward.
Yeah.
No, I understand that. It's just that, again, so if a child lives in the Antelope Valley, which is, I don't know, 110 miles away from the heart of Los Angeles, and moves to Long Beach, and they change primary care provider, that doesn't become active until the 1st of next month. So what happens to that child who needs primary care during that sort of dead zone?
Right. And that's what we need to look at and see if there's a way that we can do exceptions for where that care is received or how they receive that care. So that's one of our takeaways that we need to work on with regards to that also, because we're aware of that happens, and then you're in that limbo stage. Now, normally what happens is that they're depending, and that's the other thing that happens, is that if they're with a primary care provider who's part of an IPA, because then that IPA is capitated, that group is capitated. Do we reach out to that IPA and say, okay, go ahead and see that individual? The majority of the primary care providers, what we've seen is that if somebody comes in and they're in that transition process, they go ahead and see them anyhow. And then we work on the back end in regards to the reimbursement. But that's a question we can take back, and we'll talk to our team about on how that's going to be handled.
Great, thank you. All right, well, I really appreciate our partners from Anthem being with us today to help us better understand the services that are covered under Anthem, the MOU process, and how counties can work with the CWS liaison and the team supporting foster youth that have Anthem. I think we did put in the chat, we have a quick survey. It's only like 6-7 questions. If you could help us look at, did we meet your needs for this meeting today? And how can we at CWDA and CFPIC continue to meet the needs of counties as you continue to engage in the CalAIM initiative across the state? Again, thank you so much, and see you soon. Thanks.
Thank you. We appreciate your time, and thanks for putting this together, Baljeet. We really appreciate it.
Yeah, thank you.
Thanks, everyone.
Thank you.